Definition: any blood loss from gastrointestinal source above the ligament of Treats, that is from esophagus, stomach, or duodenum. Ligament of Treats is a band of tissue in the abdomen which anchors the duodenum and the jejunum.
Okay.
Present at the duodenojejunal flexure.
Go ahead.
Manifestations: upper GI bleeding can present as overt or occult bleeding. Overt bleeding includes hematemesis, melena, or hematochezia. Hematemesis is bright red emesis or the coffee ground emesis. Melena includes black tarry stools with a distinctive smell. Hematochezia rarely presents as the upper GI bleeding, which is the passage of red or maroon blood from the rectum. Occult GI bleeding presents with the symptoms of blood loss or anemia like lightheadedness, syncopal attacks, dyspnea, orthostatic hypotension, or hypovolemic shock. Hematemesis is coughing of bright red blood, and melena, we can see the black tarry stools.
Yeah, it will have a peculiar smell also. Blood, yes, when it is digested by the intestinal bacteria, it's not only is very dark tarry stool, it has a specific odor, bad odor of decaying blood. That is very evident. Okay.
Yes, sir.
So I remember that odor part also.
Okay, sir.
No, tell me.
Coming to the etiology of upper GI bleeding, etiology most common cause involves the gastric ulcer or the duodenal ulcer. Next, coming to next most common cause is NSAIDs, esophageal varices or the gastric varices, Pylori viscera, reflux esophagitis, gastric carcinoma, hemorrhagic gastropathy. Uncommon causes includes hereditary telangiectasias, pseudoxanthoma elasticum, blood dyscarrias, ulefoil lesions, portal gastropathy.
Yeah, these are all. Most important thing is you should not miss this. Okay. Yes. Because this is going to be a big problem. So no one wants to miss gastric cancer, though it is not very common. Nobody would like to miss the gastric cancer yes, when there is a presentation of upper GI bleed. So there is a protocol. That protocol says if the person is above 45, if the bleeding has occurred enough quantity, not just streaks of blood, it is imperative that you do an endoscopy within 24 hours. Why? One thing is to localize the bleeding. Two, to exclude rare though gastric carcinoma. What is the common thing? Gastric ulcer may be there. People are coming very late. Not able to concentrate. So the gastric ulcer part and the peptic ulcer part, okay, both are very common. And NSAID cause also is very important. Alcohol, NSAIDs, the linear tear, Pylori viscera, reflux esophagitis is a common cause. Variceal bleeding with the history of jaundice and liver disease is a very important thing. And sometimes gastric erosions may be there. Many a time you see a report from the endoscopist, gastroenterologist, he says diffuse gastric erosion C. The common cause is H. pylori. Sorry, you should not write capital P. Pylori.
Yes.
Okay. H. pylori. So if somebody asks you, what could be the cause? The patient said, sir, my father has come with bleeding from his stomach and he has vomited blood. What could be the cause, sir? He will ask. What is his age? 75. Okay. Possibility of malignancy is quite strong. Younger patient, peptic ulcer, duodenal ulcer, alcoholic, drug history, very important. Does he have liver disease, jaundice, bloated abdomen, liver failure, variceal bleeding? And rarely it could be gastric carcinoma also, the history itself. And he suffers from reflux esophagitis very often. That could have produced a bleeding from the Barrett's esophagus or reflux esophagitis. Okay. Not only you have to understand the diagram, you keep the diagram in the back of the mind when you evaluate the patient. What is the history of gastric ulcer or peptic ulcer, dyspeptic symptoms, NSAID use, alcohol use, and then variceal bleeding, and then any other hemorrhagic gastropathies. These are, better you forget. I don't require you to remember them. Some only important thing which is not listed here is use of antiplatelets and anticoagulants. Okay?
Yes, sir.
Somebody is using aspirin, clopidogrel, P2Y blocker, that is clopidogrel, or any other antiplatelet agent, because nowadays the cardiac problems are very common. So people are put on aspirin and clopidogrel, sometimes a combination of both, and sometimes they use anticoagulants for different reasons, like heparin or low molecular heparin or dabigatran or any of those things. They can cause bleeding, sudden bleeding. I have my cousin who is around 55 years now. He was having associated cardiac problem. So I have put him on aspirin, low dose aspirin, 75 milligrams. For the last 4 or 5 years, he has been taken. He's been taking the drug. Suddenly, one day morning, he found out, sir, I am having very dark stool. Then immediately I asked him to come to Manipal Hospital. We did an endoscopy within 24 hours. Found out that there are diffuse gastric erosions because of the use of aspirin. So what did we do? We stopped aspirin, gave him double dose PPIs, IV, stabilized him, and he is now all right. Now we are cautious in reintroducing the aspirin because he has to take aspirin. So we told him, so this could cause again the bleed. You be aware when you are taking it, might have black stools. Immediately you come and report. Okay.
Okay, sir.
It's a very important point. So what are the causes now you will say? Peptic ulcer, which includes gastric ulcer and duodenal ulcer. Peptic duodenal ulcer in the young, gastric ulcer in the elderly. Second thing is NSAID. Third thing is alcohol use. Fourth thing is aspirin and other allied antiplatelet agents. Fifth thing is liver diseases producing variceal bleeding, gastric varices or esophageal varices, and any other cause of gastropathy. And finally, a patient who is elderly, always keep the possibility of the elephant. You should not miss the elephant. That elephant is cancer because early detection is cure for that person. And Sotan-Osler-River-Rendu syndrome, forget about it. If you don't learn it also, nothing is lost. Pseudoxanthoma elasticum, nothing is lost. Blood disgraces are important, like hemophilia, other blood disgraces. Urinary gastric vascular abnormality, 1 in a million we will see. We will never see. Portal gastropathy, quite common. Aortic graft surgery with fistula. Nowadays, we're doing a lot of grafting for the aorta. There could be a fistula into the stomach from the aorta. It could be some important cause, but I don't think you should be concerned as general physicians about other uncommon causes. Okay.
Okay, sir. Most common cause of Apogee bleeding is peptic ulcer disease, which is secondary to duodenal ulcer, which is most common, followed by NSAID use, H. pylori, stress-related mucosal disease, and antiplatelets and anticoagulant drugs.
Yeah, that's very important. You have not written there. Better you write. NSAID is with comma antiplatelets, anticoagulants.
Okay,
very important. H. pylori in our country, because nowadays better because people know to use bottled water when they travel in trains and all. But if they take unprotected water, H. pylori is a waterborne contaminant like your amoebiasis. So people who drink unprotected water are very prone to H. pylori. Another problem with H. pylori is it is not easy to go. Infection sticks to the stomach and also it recurs. Either you treat him 3 weeks, 2 weeks treatment with triple drug, eradicated, and again after 1 month he comes back. So what you have to advise is ask them to wash hands before and after taking food and after going to the toilet and use safe water only to drink. Okay? And in the toilets, we have the habit of when brushing the teeth, we would like to put the tap water in the mouth and wash. This tap water is from where? It is from the tank, which is never cleaned, probably from the time the GEMS is installed. The tanks are not cleaned now. Not only GEMS, anywhere, even five-star hotels. The cleaning is not perfect. So what you have to do? For rinsing your mouth, use drinking water separately in a tumbler. You keep it and rinse the mouth with that water and not the tap water. This is what I do to avoid gastrointestinal infections, particularly H. pylori.
Okay. Malarial stare. It is a linear mucosal rent near the gastroesophageal junction, which is associated with vomiting or retching. Most commonly seen in binge alcoholic patients. It is generally the bleeding from the submucosal artery.
Yeah, it's quite an important differential diagnosis, particularly alcoholic says, I had a binge drinking, means excess drinking previous night. Next morning he retches because of alcoholic gastropathy, and then that retching will produce a tear which is very linear like this. Okay, and that is common in him. It is self-subsiding. It is a benign cause of hemorrhage. You don't have to worry about it. Confirm it is malarious. Treat him conservatively, and nothing is lost. And he should not repeat the alcohol. Okay.
Okay. Coming to the approach to the patient, proper history regarding the use of NSAID drugs, antiplatelets, anticoagulant drugs should be taken, and any history regarding alcohol should be taken.
Okay.
Initial assessment, pulse rate, patient presents with tachycardia, hypotension, signs of dehydration should be checked, and signs of liver failure should be seen to rule out variceal bleedings. Liver cell failure signs include spamarygma, spider angiomas, gynecomastia, jaundice, ascites.
Correct. The most important thing is he decompensated? A bleeding which is exsanguinating bleeding is very rare. Exsanguinating means person dying with blood loss. It's very rare. What happens is the hypovolemia produces hypotension and shock. That can lead to death. Not the total amount of blood lost, hardly 400-500 ml at the most. That can be managed by the body. But the circulatory status collapse is the one which will be a problem. So that you have to assess. That separates people with red flag signs from those who don't have the red flag. What are the red flag signs? One, age. Two, the acuteness of bleed. Please write down. Age is an important predictor of this. Second thing is they have a scoring system also. Second thing is the after the age, the quantity of blood, the hypovolemia, tachycardia, hypotension, one creatinine ratio. What is that? One creatinine ratio?
To rule out prerenal
No, not prerenal. Blood urea nitrogen is a degradation product of the proteins in the blood. When somebody has got a bleed into the GI tract, there will be a lot of absorption of the nitrogen products, and BUN will be very much more compared to creatinine. Normally, BUN is how much? 12. Creatinine how much? 0.8. Roughly, the ratio is 15. BUN creatinine ratio. In this patient, creatinine is all right because kidney has not paid, but this becomes 80. Then what will happen? It will be 100. BUN creatinine ratio is a very important indicator of a large GI bleed for over more than 24 hours. First of all, it should be large quantity. Second of all, it should have sufficient time for it to get converted into nitrogen and get reflected as BUN. The difference between BUN and urea is a molecule which is having nitrogen. The nitrogen part of that urea is called BUN. You understand? Urea is a complex inorganic molecule, a complex molecule, of which the nitrogen is an important component. If you estimate only the nitrogen, it is BUN. If you estimate entire urea, it is urea. That is the difference. Normally, urea is around 20, burn is around 10. Okay.
Okay, sir. Evaluation. Complete blood count, which includes hemoglobin, hematocrit, MCV, MCHC, and platelets. Coagulation profile, PT, APTT, PT with INR. Renal function test, which includes increased 1/creatinine ratio. Scoring systems predicts the risk of rebleeding, mortality, and need for intervention. And lastly, endoscopy.
Correct. So you have already mentioned here 1/creatinine ratio, which I have already explained. Coagulation profile is important, particularly people taking anticoagulants, and you have blood dyscrasias. And then the endoscopy is an important tool to differentiate major bleed from minor bleed, red flag bleed with benign bleed. That's also important. The scoring system, anyway, you have mentioned. I am glad you mentioned in your presentation. In fact, I want to tell you, though you are a first year PG, you made a very good effort to learn the subject and present it, for which I am quite happy. Okay.
Thank you.
Okay.
Scoring systems, Rockwell scoring system, which predicts the rebleeding and mortality, which includes age, shock, comorbidity, and diagnosis post endoscopy diagnosis.
Correct.
Age
Each is scored as 0, 1, 0, 1 or 0, 1, 2. Okay. 1, 2.
Yes. Greater than 8, it's a high risk, considered as a high risk for rebleeding and mortality.
Correct. Less than 2 is no risk. Okay, 2
Yes.
or less, no risk. 2 to 6 or 7 is intermediary. Beyond that is a high risk for rebleed. Okay.
Yes.
Very obvious. Age is important, as I told you. Age is a very important factor. 1 second. My power, computer power has to be given. Okay. Okay, go ahead.
Yes, sir.
Next slide, I will.
Sir, should I say all the scores, sir?
Not required. It's obvious, no one can read.
Okay, sir. Blatchford score predicts the need for intervention. Markers include the blood urea, hemoglobin levels, systolic blood pressure, and pulse rate. Presentation and any history of melena, syncope, hepatic disease, and heart failure.
Yeah. This is called Glasgow Blatchford score. GBS is called. Glasgow. Glasgow is a place in Europe, very near to London, where Royal College of Physicians is there, for which I am a fellow from the Glasgow University. Right? So like that, Glasgow is a wonderful place. And then the point here is, you have what are the important markers? What is the hemoglobin level? Is there a drop in the hemoglobin? What is the systolic blood pressure? What is the pulse rate? Decompensation happening? Is there melena, syncope, and then hepatic disease or heart failure, coupled with blood urea nitrogen? Okay, and there are numbers given, and those numbers you add up. If it is 0 to 2, then low risk. Anything more than that, it is higher risk. Okay. Very simple scoring. What do you require? You have to measure the hemoglobin, look at the blood urea, to take the blood pressure and heart rate, and take the history of melena, syncope, and hepatic disease. You're not asking for a CT scan or anything. When it is done before the endoscopy.
Yes.
Okay. This is preceding the endoscopy. If a patient presents to me over the phone, the nurse will tell, sir, one patient is admitted. Ask the junior doctor to see. Yeah, the resident will go and senior resident will go and see. I'll ask him, what is his hemoglobin? Yeah, immediately he will tell. What is his blood pressure? What is his pulse rate? Is he having history of melena and syncope? Is he a patient of liver disease? Is he in heart failure? Get blood urea nitrogen done. Yeah, after 1 hour he phones blood urea nitrogen. Now work out the score. You will tell me, okay, now admit him. And he is less than 2 or a quarter. And then immediately. So you have to ask these questions. When you become a consultant, you have to keep in mind this scoring. It is not a very difficult scoring, very simple to use. Your medical case itself is having this. If you punch these numbers, it will give you the prediction. Okay. If you don't know what is medical, all of you download this app. Medical. This app you must have in your phone. You may be having several apps for your mobile phone. This also you download.
Sure.
Okay. Okay. Not only for this scoring, it gives almost 1,000 scorings related to clinical medicine. Okay.
Okay, sir.
Now what do you do?
Coming to the management, first securing 2 large IV cannulas, 18 gauze, adequate hydration to maintain blood pressure and hemodynamic status, elective intubation if patient has any difficult airway or with severe ongoing hematemesis, blood transfusion to maintain a hematocrit about 20% and in high-risk patients greater than 30%.
And here they have written you should not expect the hematocrit to be 40. And you should not try and push it to that level because it may endanger into heart failure. Loading with fluids also is not very good. And hematocrit should be maintained around 30%, normal being 45%. So if you keep it around 30%, it is good enough to save his life. Okay.
Okay, sir.
Next management.
Next, proton pump inhibitors. Patients with significant bleeding, we give 80 milligrams bolus of proton pump inhibitor followed by continuous infusion.
Okay.
Endoscopy should be performed within 24 hours, irrespective of the risk status, whether high risk or low risk.
Yes.
Sense taken Blackmore tube is done before endoscopy in case of uncontrolled bleeding or known case of esophageal varices.
Yeah, you have shown that picture also, sun taken tube. No, that is not for everyone. When you are suspecting variceal bleeding, when do you suspect? When there is a previous history of variceal bleeding or when the patient is having history of chronic liver disease in the form of jaundice, Pyder nivae, and palmaredythema, gynecomastia, ascites, pedal edema, liver failure, all those things will be there. Then you are justified in putting a sun-taken tube. So PPI is usually 80 milligrams of bolus PPI. Normal dose is 20 milligrams of pantoprazole or 40 milligrams of omeprazole. Esomeprazole also 20 milligrams of the dose. Here you use 80 milligrams of omeprazole or 40 milligrams of pantoprazole as a continuous infusion. Then later on you can switch on to BID injection or oral dose later on. So PPIs are very important because they will definitely reduce the risk of further bleeding. Okay, endoscopy has to be performed irrespective of what is your score. Why? Because we don't want to miss the cancer, an elephant. So we do an endoscopy. The protocol says if there is a history of bleed and or if the patient is more than 55 years, any dyspepsia, you have to do an elective endoscopy. If there is a bleed, within 24 hours, you have to do. And studies have shown that doing immediate endoscopy has not produced much different results compared to doing within 24 hours. Don't be in a great haste to do the endoscopy. Before that, you ascertain all the details, look at the failure, look at the scores, predict the outcome, and then start the IV drips, 18G cannulas associated with PPIs, maintain the hydration, maintain the hemodynamic status, then consider endoscopy within 24 hours. Endoscopy is not the first thing. Okay?
Okay. Picture showing sense taken Blackmore tube, which includes esophageal balloon and the gastric balloon.
What is that? Why there are three lumens?
One for esophageal balloon inflation, another for gastric aspiration, another for gastric balloon inflation.
Correct. There are two balloons which are connected by two separate things. Esophageal inflation part is on one side, gastric inflation part on the other side. The central channel is to aspirate the content.
Yes.
So by putting pressure on the esophageal, very cheap, as though you have put with a cotton pad, you arrest the bleeding. No? Suppose there is a skin bleeding. What you do? Sterile cotton you take and a cotton pad and press it against it and keep it. The same thing is done. Mechanically, the vessels are compressed, and that compression leads to immediate stop. It's a very successful procedure. Have you seen this in your department?
No, sir.
You go and ask. So there will be a second tube definitely available, particularly in the gastroenterology department. All of you go and ask them to show you how it looks like. You must know what are all the instrumentations you are doing. You must, at least before leaving the college, you must have seen one. You can't say Sangstack and only the name will be remembered. If you see it, forget about the fellow's name. He has invented, so keep his name, no problem. But knowing it is important, and how to use it also is important. Okay.
Okay. Next, forest classification. We type 1 active bleeding. 1A includes a spurting hemorrhage. 1B is ooze. Type 2 involves recent signs of recent bleeding, in which it has a 2A non-bleeding visible vessel, 2B adherent clot on lesion, 2C hematin covered lesion. Type 3 is lesion without bleeding.
Where did you draw this from? This particular forest classification. What is your source?
Have seen in Harrison, sir, downloaded in Google.
Okay, good. It's good. It is this is an endoscopic diagnosis. Once you put the endoscope, is there a blood vessel spurting with hemorrhage? Certainly, it's very dangerous. There is a small ooze, no spurt, fine. Type 2, recent bleed is there, no active bleed, non-bleeding blood vessel is seen, but open blood vessel, but it is not bleeding. But that means already clot has formed. Or an adherent clot is there on the ulcer or the lesion, or there is a hematin covered, brown colored, this one is there. Or there is a lesion without any bleed, flat spot, clean base, small ulcer, and or erosions, diffuse erosions. There is no specific area there bleeding. Diffuse gastric erosions, erosive gastropathy. Okay. Now,
coming to the treatment part, if the endoscopic diagnosis showing ulcer, which has an active bleed or a visible vessel, we do endoscopic therapy plus intensive PPI therapy and clear liquids for 2 days. Duration of hospital stay is 3 days.
correct.
If there is an adherent clot, intensive PPI therapy is given with or without endoscopic therapy, clear liquid for 2 days, and hospital stay for 3 days. Flat pigmented spot is seen, no endoscopic therapy is needed, and PPI once daily is given. Clear liquid for 1 day and hospital stays for 1 or 2 days. If there is a clean base, no endoscopy therapy is required, PPI once daily and regular diet is allowed. Discharge after endoscopy.
Yeah, this is from the Harrison. They have nicely summarized it. There are 2-3 other columns also, but you have picked up only the important columns, like active bleeding with a visible blood vessel, adherent clot, flat pigmented spot, or a clean base. Good.
Intensive PPI therapy includes IV bolus of 80 milligrams PPI followed by 8 milligram per hour infusion for 3 days, or oral or IV bolus 80 milligrams followed by intermittent high doses, that is 40 to 80 milligrams BD or 40 milligrams TID, followed by twice daily PPI for 4 to 14 days, followed by OD dose of PPIs.
Correct.
Endoscopic therapy includes bipolar electrocoagulation, heater probe, injection therapy. Injection therapy includes either absolute alcohol or epinephrine 1 in 10,000.
Correct.
If the endoscopic diagnosis reveals esophageal varices, we give vasoactive medications like octreotide, somatostatin, vapriotide, or terlipressin for 2 to 5 days. Endoscopic therapy includes endoscopic variceal ligation, variceal sclerotherapy, stent placement, balloon tamponade with Sengstaken and Blackmore tube, and non-selective beta blockers plus endoscopic ligation is recommended to is recommended for the reduction of recurrent rebleeding. And last therapy, if there is a persistent or recurrent bleeding that is three failed attempts of endoscopic parietal ligation, we generally prefer TIPS, that is transjugular intrahepatic portosystemic shunt. It is also preferred in acute variceal bleed with advanced liver disease.
Correct. TIPS is a very common procedure for variceal bleeding here. Now, so you go through the algorithm.
Acute variceal bleeding.
Yeah.
First, we do the resuscitation. We check the airway, breathing, and circulation. And volume resuscitation. After doing the volume resuscitation, we give the vasoactive drugs for 2 to 5 days, telepressin, somatostatin, or octreotide. And then we prefer endoscopic treatment, that is band ligation. If bleeding is controlled, we go for secondary prophylaxis with non-selective beta blockers. If there is any high risk like advanced liver disease with child pug score B or C, and we prefer early TIPS for uncontrolled bleeding or treatment failure. We perform balloon tamponade and metallic stunts. If not controlled, we go for TIPS. Diagram showing the TIPS connection between hepatic vein and right hepatic vein and the right portal vein.
This is the portal vein. Okay, there is portal hypertension, and the blood wants to bypass into the systemic circuit. Varices are formed. What do? We ourselves create a bypass. Don't worry, we will create a bypass for you. You go, all the blood will go through the stent into the hepatic vein and through the hepatic vein into the inferior vena cava. And then instead of the nature producing a channel through the esophageal varices and gastric varices, we ourselves have created from the right portal vein, right branch of the portal vein to the right hepatic vein, into which ultimately empties into the inferior vena cava. Okay, this is called the transjugular, because we have going through the jugular vein to reach this site. Intrahepatic, because the portal vein right branch and the right hepatic vein are intrahepatic. It is a portosystemic shunt. Portal systemic circuit shunt. Can you tell me why it is called a portal vein? Portal. Any idea? What is portal vein?
No, sir.
Don't know. Well, who is a porter? No porter?
Sir.
You know, transport?
Yes, sir.
Port means from one place you take to another place. That is called porting. Porter is not a derogatory designation. He takes luggage from one place to another place. That is not a derogatory word. Porter means is helping to take this luggage or this cheese in Hindi, this particular vastu from here to there. Transport. It transports from Vijayawada to Vizag. Transport. What is this doing? This is also doing a porting job. What is it porting? It is porting all the gastrointestinal good contents as well as digestive contents, all those things into the liver, so that it will segregate what are all the bad things, what are all the good things which should go. It will put it in the check post or in the port. It takes it to the port. The portal vein takes all the blood to the port, where it is sorted out, and the excretory part is sent into the biliary canaliculi. Useful part is shunted into the hepatic vein for absorption. Okay, that is why it is called portal vein. Systemic vein means it drains the blood from all the systems. What are the systems? Limbs are there, upper limbs, lower limbs. And then you have the kidneys, you have the pelvic organs, you have all other organs there, and all the systems are being drained. That is why it is called systemic circulation. Okay?
Okay, sir.
Okay. Must know the words.
If the endoscopy diagnosis reveals a Mallory Wister, check whether there is an active bleeding is there or not. If active bleeding is present, endoscopic therapy is done. For any ongoing nausea, antiemetics are advised. Hospital stay is for 1 to 2 days.
Correct.
If there is no active bleeding, no endoscopic therapy is required. Antiemetics are advised for ongoing nausea, and regular diet is advised, and discharge after endoscopy.
This is one of the benign conditions of hematemesis. Okay.
Endoscopic diagnosis showing erosions. No endoscopic therapy is required. Once daily PPI therapy is advised. Regular diet. Discharge after endoscopy.
What treatment I do endoscopically? Because it is not in one place. It is diffuse erosions. At best, you can use now along with PPI sucralfate.
Okay.
Sucralfate coats the stomach. It coats the layer of the stomach and then gives comfort and stops further bleeding because it is diffuse. Sucralfate 10 to 15 ml of sucralfate is given 3 times a day, available as sucralfate. Okay, sucralfate. Alginate also is very useful. Alginic acid, megaldrate, alginic acid, sucralfate. These are very useful antacids. Not regular, the antacids, not regular antacids that we use. Okay, like magnesium hydroxide, calcium hydroxide. Some gels you use. Don't give Digene gel or the Gelusil or better you use megaldrate and then sucralfate and things like alginic acid, like that. Preferably with an anesthetic agent. Oxytocin is an anesthetic agent, and it comes, the bottle will have some agent -O. O means the anesthetic. Esenyl O means what? O is the oxytocin compound. You can use that also. Add with oxytocin, the pain part of it will be arrested by the local anesthesia of the stomach mucosa. Okay?
Okay. Next, coming to the preventive therapies to reduce the occurrence of rebleeding. For H. pylori induced bleeding, Apogee bleeding, we eradicate the target. Eradication is the target. For NSAIDs induced, we use stop the offending drugs and start using COX-2 inhibitors plus PPIs. Patients with established cardiovascular disease, presence with bleeding ulcers, and patient is on low dose aspirin for secondary prevention. We advise the patient to restart aspirin as soon as possible after the bleeding episode within 1 to 7 days. If the same patient is using aspirin for primary prevention, we advise the patient to discontinue aspirin.
Look here, this is what exactly I told about my cousin. He was being given aspirin for a secondary prevention. So what I did, I stopped the aspirin, evaluated him, bleeding was controlled, and I restarted it within a week or so, and then told him to watch for any signs of GI bleed. Suppose it is being used by primary prevention. For example, anybody above 65 is a candidate for use of aspirin as a primary prevention. That means it doesn't have any heart disease as yet, but it is a primary preventive rule. We are using aspirin in such a situation. If there is a bleed, you stop it. Because it is only for primary prevention. There is no established cardiovascular disease in him. So the bleeding is more riskier than an unpresent cardiovascular disease which is going to be prevented. So this is the indication. H. pylori I consider in the prevention not only eradication, education about the safe water. Because H. pylori is a reinfection, just like any waterborne infection. Safe water use, hand washing, hand hygiene, have to be really educated to the patient. NSAIDs, we stop the NSAIDs, ibuprofen, diclofenac, indomethacin, like drugs you stop and start giving COX-2 inhibitor. What is COX-2 inhibitor? Celecoxib. Celecoxib, not alone, along with the PPI. So he gives a omeprazole and celecoxib. Because the arthritis is bothering her. So if you stop the celecoxib, NSAID, she will not be able to even move. So you have to treat her. Then change it to selective inhibitor, COX-2 inhibitor, combining with the PPI. Okay? If he is an alcoholic, ask him to stop alcohol. But if liver disease, you treat appropriately. Oh, thank you. Preventive measures only this much. So you have to, and somebody is on antiplatelets, you have double antiplatelets, you have to make them have only one. Step 2, somebody has got using anticoagulants, they have to weigh the risk benefit of using the anticoagulant. Somebody has got blood dyscrasia, identified properly, guide them, and you can put them a band on the hand. This person is having hemophilia. The moment they notice any bleed from him from any part of the body, they alert the people around and they go to the hospital immediately. So this is what you have. A good thank you also is there. As I said, this presentation is more or less good and satisfactory. Okay. Then what do? We have to use the other informations we have. So let us share them. Okay, screen sharing shop. So I will try to share some of my screen. Hopefully, yeah. Can you see?
Yes, sir.
Are able to see. I'm able to see in the other computer. There is a chart box, something is there. IV pantop 80 milligrams equally effective as infusion. Yes, you can use IV pantop also. Yeah. PPA infusion will continue, not required. The bleeding stops, you can stop the infusion and go for IV doses. Okay. So PPA infusion, the bleeding is continuing, you continue for 3 days. By that time, you would have arrested the bleeding. Okay. Type your questions like that. Very nice. Now, this is about the gastrointestinal bleeding in Davidson. Davidson, wonderful book. I always liked Davidson from the beginning. So you see here. So, alcoholism, NSAIDs, infections, metabolic causes, psychogenic, central nervous system disorder. It's more about the causes of vomiting that are listed here. And this vomiting may be associated with bleed also, particularly the gastric and duodenal ulcers, and then the gastric and duodenal ulcers, and also the cancers there, NSAIDs and all those things. Okay, now let us go to this is the modified Belchford Glasgow score, GBS. That's what you have shown. Blood urea, hemoglobin for men, hemoglobin for women, systolic blood pressure, other markers like syncope, hepatic disease, cardiac failure, heart rate, presentation with melena, none of the above is 0. Add up the score, and depending on that, you start treating it. Okay, very important to use the scoring. This is very simple also. And along with that, full blood count you get done, and also look at the urea and electrolytes. Urea one creatinine ratio you obtain, liver function test, prothrombin time. Keep a cross-matched blood because you might require blood. Very important. That point we have not brought out in the presentation. Immediately send the blood for cross-matching and make blood available. What are the causes? Yeah, same thing what diagram you have put. He has also given the percentages. Most common is peptic ulcer. Okay. Peptic ulcer with the tools I will first push. So you see the commonest cause is peptic ulcer. Okay.
Yes, sir.
Next important thing is, for example, is diffuse esophagitis. Okay. And then you have got the variceal bleeding. Okay. Then the malarial. Then the cancers, not very common. Gastric erosions, NSAID alcohol, very frequent. 1, 2 is the second common. 3, 4, 5, 6, and 7, 8. This is aortic fistula and all. This is aortic fistula, aortoduodenal fistula. This is the cancer, the gastric ulcer, this is the peptic ulcer, this is the varices, this is the Mallory stare. All the things we have brought out diagrammatically. This diagram will immediately tell us, just as what you have projected, should also allow us to look into the history, causes of acute upper GI bleed. Frequency is given in parentheses, NSAID, non-steroidal, anti-inflammatory, resuscitation, oxygen, endoscopy, monitoring, surgery. What is the surgery you can offer? Suppose the bleeding is not controlled, whatever you do. What does the surgeon do? To try to ligate and all that is not possible. Partial gastrectomy. Maybe, or you can do several procedures. One of them is plication like thing, underrunning we call. We call duodenal ulcer treated by underrunning. That means the blood vessels under the ulcer are sutured so that the ulcer will not bleed. Or underrunning of the gastric ulcer, underrunning of the duodenal ulcer, or you can do a partial gastrectomy as a last resort. Not everyone requires it. Now let us say Harrison. You have seen part of it, Harrison part of it, and then you can also just look at what is given in a sort of gross way, whether we have missed anything. So what he says here, yeah, there is upper gastric, UGIB it is called. Upper LGIB, lower gastric. How do you differentiate lower GI bleed from upper GI bleed?
So, history of vomitings.
See, even if the bleeding is in the upper GI tract, can go down and present as melena.
Yes, sir.
Right?
Yes.
So hematochezia is not very commonly from the upper part, it is from the lower part. That is directly bled in the motion. There will be some causes, local causes, rectal causes, and other things. Okay?
Yes.
Altered blood may be there in both. So what he says, upper GI bleed, NSAIDs he has given, and then ulcers he has given, peptic ulcer part he has written, NSAID he has said, peptic ulcers are discussed elsewhere, Mallory he said, esophageal varices he said, tips he has said, IV vasoactive medication, octreotide, somatostatin, piperitide. You have taken this from this particular page only. You have taken this. I could easily see that. Good that you have read Harrison. That is why I said the presentation in general is quite satisfactory. Erosive disease, that's also very important. And then other causes, very rare causes, which we are not interested. So approach to a patient with gastrointestinal bleed, you have to do the initial assessment, transfusion may be required, differentiate from upper GI from lower GI. Hematemesis indicates upper GI, melena indicates present in the GI for more than some time, and then the proximal the bleeding side, the more likely melena will occur. Okay, if it is in the stomach, melena will occur. Hematochezia, usually lower GI. Okay. Okay, this is what you have to do. Okay, and this is the one which you have taken. You have summarized and nicely you brought it. Endoscopic diagnosis, endoscopic therapy, medical therapy, diet, hospitalization. You compressed into a nice table. This is the whole thing. Very, very nice to see this. Is there ulcer? Is there varices? Is there Mallory stare? Are there erosions? Depending on that, endoscopic features are there, what endoscopic therapy, what medical therapy, what diet, and how long you will be in hospital has been listed here. That's all he has given. And beyond that, this also you have shown Glasgow by Blatchford score, blood urine nitrogen, hemoglobin, systolic blood pressure, heart rate, other markers. You have taken from this. You have also seen Proctor score also you have shown. Very nice. Okay, what do I have? Maybe I have something else to show. This you have already shown, the Rockall scoring system we have seen, particularly comorbidities, shock, source of bleeding, stigmata of recurrent bleeding. They are taken and the score is worked out. And better than Rockall score is the GBS score, which we have very much carefully looked at. There is another score which is called the AIMS 65. Okay, what is AIMS 65? Patients with upper GI bleed who have the total AIMS 65 of 1 or less is considered low risk. AIMS, albumin is taken instead of hemoglobin. INR is used. Altered mental status, systolic blood pressure, age more than 40. This is albumin A for albumin, I for INR, and mental status M, as for systolic blood pressure, age 65. That's why it is called AIMS 65. Easy to remember. A is albumin, I INR, M mental status, S systolic blood pressure, 65 and above is the age. So in this particular study, they compared various tools like Rockall score and Glasgow score, and recommended upper GI bleeding scoring systems are useful instruments to help evaluate patients with upper GI. However, clinical acumen is also important for medical care to patients with upper GI. With the use of scoring system, low-risk patients can be identified and more effectively triaged to less costly procedures. What is the purpose of the scoring? Low-risk fellow, you don't have to put him in the hospital and ICU and all that. Detailed clinical examination and hemodynamic assessment, upper GI scoring tools, Rockall score, GBS score, AIMS score. Low-risk criteria in different upper GI scoring systems are listed. Pre-endoscopic Rockall score 0 and complete Rockall score after completing a procedure 2 or less, patient is at lesser. Predict the risk of further bleeding. GBS score of 0 reduce the risk of intervention, and AIMS score of 1 or less, that also. Patients with upper GI bleed who have the total GBS at 0 are considered as low risk. They can be discharged from the emergency safely, only with 1% chance of major bleeding. Upper GI bleeding, key point. This is one important reference which you can see. There's a quiz also. Okay. So read that and answer the quiz.
A 51-year-old man presented to emergency department for 2 episodes of hematemesis and 3 episodes of melena. He is vitally stable. Hemoglobin is 9.8 and one creatinine ratio is more than 30. What is the primary reason for nasogastric tube placement in this patient?
You're not asking about anything about bleeding. You have put a nasogastric tube. What for? To determine that there is an active bleed, to evacuate the stomach clots, to give oral medications to stop bleeding, to gauge the rate of bleeding. What for is the nasogastric tube? Right?
To determine there is an...
To determine the active bleed. Yeah. Well done. That is the answer he wants. Okay. You are right. Determine if there is an active bleed or not. So if you put a tube, through the tube, if there is an active bleed, you can see whether there is an old bleed, he had hematemesis. Now is there an active bleed? For that, you will be able to see. Okay. Nasogastric tube, NGT placement, usually done in patients with upper gastric bleeding. And NGT can be used to determine if there is an active bleed. Sometimes fluid can be passed from the NGT to irrigate the stomach, followed by endoscopy to visualize the lumen. Because that is also good. You can irrigate the stomach and then endoscope you can see properly. When doing endoscope, of course, you will remove the nasogastric tube. If NGT fluid is bilious, then bleeding is most likely distal to the ligament of trees. If the NGT lavage returns mobile, both upper and lower endoscopy must be performed.
A 78-year-old man is admitted in the intensive care unit with complaints of dizziness, confusion, low blood pressure, dark reddish stools. He has a past medical history of moderate aortic stenosis and drug-eluting stent for coronary artery disease. He takes aspirin, clopidogrel, simvastatin, metoprolol, and lisinopril. He is resuscitated with normal saline and 1 unit of packed red cells, started on high-dose omeprazole infusion, and stabilized without further bleeding. A gastroenterologist performs upper and lower endoscopy, but the results are unremarkable. Which of the following is most appropriate next step in the management of this patient's condition?
So here is a patient who is in the ICU who came with systemic symptoms of dizziness, confusion, and low blood pressure because of the melena, dark reddish stools, because of the bleeding. And he was on patient of moderate stenosis, and there is a triglyceride stent and coronary artery disease, for which he is given aspirin, clopidogrel, simvastatin, metoprolol, lisinopril. Simvastatin, metoprolol, lisinopril, they don't cause any GI bleed. Aspirin and clopidogrel are notorious to cause, particularly in a susceptible individual. He is resuscitated with normal saline and 1 unit of packed red cells. Started on high-dose omeprazole infusion as per the protocol and stabilized without further bleeding. Now, a gastroenterologist has performed upper GI, negative, lower GI, that also is negative. Which of the following is the most appropriate next step in the management of this patient? Do you do a target red cell scan, a tagged red cell scan, CT angiography, Miscentric Angiography, video capsule endoscopy?
Sir, video capsule endoscopy.
What does it do, video capsule endoscopy?
Endoscope.
See, there is only one person who has seen the whole of GI tract. That is Hanuman. He went through the mouth and came through the other end of Lankini. He has seen. So the gastroenterologist can see the upper part as well as up to the large intestine. And beyond the large intestine cecum, we cannot, the endoscope, colonoscope cannot. So there is a part of the bowel which is missing from the second part of the duodenum onwards till the terminal ileum. That part of the GI tract is not available for endoscopy. So capsule endoscopy will take pictures. Patient will swallow a capsule with a camera, and that capsule is it goes through the GI tract, and very periodic pictures are taken through the small intestine, and you try to read the information. That is called capsule endoscopy. Okay. Miscentric angiography for what? There could be miscentric infarction. My friend, a very notorious, a very famous physician in Vijayawada, he had acute abdominal pain and melena. And they have done several things, but ultimately they missed the diagnosis. It is a miscentric infarction. Okay, miscentric angiography is to detect miscentric infarction, just like coronary artery blockage and infarction. You can have miscentric infarction, peripheral arterial disease, or anything like that can happen. For that, miscentric angiography. CT angiography of what you will do? CT angiography will tell what, which part you are going to do CTR. Target red cell scan, what is the tagged red cell scan? Tagged red cell scan is for hemolysis. If you tag a red cell and see how long it is in the circulation, then you can demonstrate whether that is dying early or not. So tagged red cell scan is no use. CT angiography is very non-specific. Either miscentric angiography or you have said capsule endoscopy. I will tick that, and that is correct. You have well done. You answered successfully. Because we do not want to miss that part of the bowel which is not accessible through the gastroenterologist, upper GI, lower GI. The only way I can look at it is either call Lord Hanuman or use a capsule endoscopy. So Lord Hanuman is not available now. So he is available but not in the physical form. So we will ask capsule endoscopy to do that. And okay. Now what are the teaching points? The next step in the evaluation of an older man, because he is an older man, who reports GI bleed, but is currently stable without active bleed as an unrevealing upper and lower endoscopic finding is a capsule endoscopy. In a patient with unrevealing upper GI endoscope, lower capsule endoscopy can identify the cause and location of small bowel source of GI blood loss in the absence of active bleeding. After the location of the source of bleeding has been identified, a double balloon endoscopy can be done to treat the lesion. Okay, and then patients must have minimum of 2 large bore peripheral access catheters, at least 18 gauge intravenous fluids that we have already seen. And if the patients are not able to protect their airways, you have to do an intubation also, because there could be airway arrest. So airway breathing is stopped. So you need to intubate the patient. Blood transfusion, you have to give to target the hematocrit to around 30, not more than 30. Such an elderly patient and patients with coronary artery disease, we should not overload the circulation. Elderly patients and patients with a known CAD, hematocrit should not be targeted to 40, 45, which is normal. Keep the hematocrit at 30, which is safe enough level for him to live through. There is no evidence that higher targets of hematocrit goals should be sought, as higher targets can be even deleterious or dangerous. Yeah.
Sir, how PPI infusion helps in GI bleeding? Sir?
Yeah, that's a good question. See, PPIs have got a role in this because the acid secretion is reduced. Okay? Along with the acid secretion, pepsin secretion also is reduced. Acid is a strong motility inducer of the upper GI. Okay? If they reduce the acid, the motility also comes down. When the motility comes down, the bleeding point is undisturbed. It will clot naturally. That is the idea. Not that we are treating acidity here in order to bring down the gastric motility and peptic digestion also. Because once pepsin is there, what will happen? The bleeding area will never clot because the proteolytic enzymes there will not allow the clot to form. Okay? So, if you reduce the pepsin and acid, one, the motility is reduced. You can as well use anti-motility drugs also, but that is not going to solve the problem. Peptic digestion has to be stopped. Okay? And that's why it is called acid peptic disease. Isn't it? So once the peptic digestion elements are reduced, then the ulcer will have, or the bleeding point will have a tendency to get occluded by natural mechanism itself. For that reason, you use PPI. And another thing, most of our patients are NSAID patients sometimes, and NSAID patients have hyperacidity and gastric erosions. These erosions heal only when the acid is reduced. For that reason, you have to give. Okay, H. pylori. H. pylori also is diffuse erosion. They require acid suppression. That is also required. Peptic ulcer is a common cause that requires acid suppression. So why I should not give? All my causes, NSAIDs, peptic ulcer, and then H. pylori, all warrant acid suppression.
Yes, sir.
Isn't it? For that reason, you give it. The causes are acid related. For that reason, you give it. Okay?
Okay.
Okay. If the tears are there already, insertion of nasogastric tube could be dangerous. No, it is not. Nasogastric tube is very soft tube and doesn't have any rough edges. And Mallory Weiss is a very small proportion, isn't it? So nasogastric tube will be in place. That tells you whether there is an active bleed or not. That is the point we have to understand.